Hi there. My name is Hassan Salam. I'm a professor in obstetric and gynecology in Alexandria University, and today I'm going to talk to you about optimizing embryo transfer. Now, this is the lecture outline. At the beginning, we're going to talk about the technique of embryo transfer, then the factors affecting embryo transfer, and finally, the management of difficult or intractable transfers. So, how do we do the embryo transfer? Well, usually we put the patient in a lithotomy position. We do cleansing of the cervix with saline or any culture medium with the proper osmolarity and pH. We remove the cervical mucus gently in a manner not to injure the cervix, not bleeding. We measure the length of the uterus by ultrasound, although we could have done this before. We insert the outer teeth of the catheter under ultrasound guidance, and then we ask the embryologist to bring the uh, embryo the embryos inside the inner catheter, and then we deposit the embryos either by the embryologist or by ourselves. This is, of course, if we are doing the post loading method, as we are going to describe. Then we wait for about 30 seconds. We remove both catheters, and then we rest. We ask the patient to rest for about 3 minutes. Now, again, as I said, a lithotomy position. Most of the people will do the embryo transfer in the lithotomy position, as you can see here. We do the cleansing of the cervix with a swab, cotton swab or similar, gently, as I said. Then we aspirate the cervical mucus if we can see any cervical mucus, again taking care not to injure the cervix. Then, as I said, we measure the length of the uterus. Again, we know the direction of the uterus. Is it anteverted? Is it retroverted? And so on. We could have done this before, but of course the uterus can change position, particularly if the bladder is full or the rectum is full and so on. Then, again, as I said, we could have done a dummy embryo transfer before, which will tell us the direction of the uterus and again the direction of the cervix itself. Again, because if we know the direction of the uterus and the utero-cervical angle, we can bend our catheter according to this utero-cervical angle. Some women have a straight uterus, and sometimes we have a mild angle, a more obtuse angle, or a retroverted uterus. And here's the inner sheath and the outer teeth if we're going to do the afterloading method. And as I said, there are two methods of embryo transfer. There is the afterloading catheter, which means that you put the outer catheter, then we ask the embryologist to bring the inner catheter with the embryo or embryos inside it, as I said, and then we deposit it. On the other hand, some people like to do the preloading method, which means that they bring the catheter with the embryos already inside the catheter, and then they go with the embryos in one go and then deposit the embryos. This, of course, carries the risk of having a problem during negotiating the cervix, and then the embryos will stay outside the incubator for a long time. And as I said, we put the outer catheter, then we ask our embryologist to load the embryo or embryos. Usually, he or she would do this in between two air bubbles, and sometimes we have another drop in front, another drop behind, as you can see here, and making sure that the embryo or embryos are put in a minimal amount of culture medium. And again, as I said, we go inside the uterus. We make sure not to hit the fundus. In fact, the more away from the fundus you are, the better the results. Then we deposit the embryos slowly, gently, and then we wait for 30 seconds, as I said, and then we go outside. At least this is the way we do it. This can all be observed under ultrasound guidance, and as you can see here, when you inject the actual embryos, the culture medium drop which contains the embryos with slight air before it or after it, you can see these air bubbles going inside the uterine cavity. And again, we give the embryo back we give the catheter back to the embryologist, and she or he will look under the microscope to make sure that there are no embryos left in the catheter. If this is the case, we may decide to freeze them and put them in a subsequent cycle, or to put them back in the same run. Then we ask the patient to rest for 3 or 5 minutes, as I said, because longer than this is not necessary. So this is the technique we do it, and most of people will do it this way. So what are the factors which affect the embryo transfer? Because people always ask us or ask about these factors. For example, what is the best position for having the embryo transfer? And there are different factors. We're going to see them one by one. What is the best position? People have experimented with the knee chest position versus the lithotomy position. But is it better? Well, this was a case control trial performed a long time ago by Engels, and they did not find any difference. In fact, only 50 patients versus 50 patients. What about general anesthesia? Should we give general anesthesia to the patient? Well, again, it doesn't seem to make much difference. This is, again, a long study which has been performed a long time ago, and it is only a case-controlled trial. It is not a randomized controlled trial, but in all cases, there was no difference in the pregnancy rate, the clinical pregnancy rate, between giving general anesthesia or not giving general anesthesia. Acupuncture was also tried. And in fact, does it make any difference? Well, at the beginning, there were some randomized studies showing that it does give some benefit. It increases the clinical pregnancy rate. But some studies did not agree. And then when the meta-analysis was done by Tariq Touhi from St. Thomas's Hospital, London, there was no difference, in fact, between giving acupuncture or not giving acupuncture in the clinical pregnancy rate and in the live birth rate. And this is the forest plot. As you can see, this is the clinical pregnancy rate, and it does not change. What about being gentle and atraumatic and having an atraumatic technique? Well, this is important. This is a meta-analysis we have conducted a long time ago. And as you can see here, if you are gentle, you have a better result concerning the clinical pregnancy rate in the forest plot, and also the implantation rate, as you can see here. What about having a trial embryo transfer before the actual transfer, a dummy embryo transfer? Well, people do this. And these are two studies from the literature, one by Khaldun Sharif from Jordan and one by Ragam Mansour from Cairo. And as you can see here, both of them claimed a better result when you do a dummy embryo transfer. For example, if you look carefully at the Mansour study, which was a randomized controlled trial where there was a better clinical pregnancy rate, as you can see here, 22.8 versus 13.9. Mind you, this was a study conducted more than 30 years ago, and as you can see, the results were not impressive. I mean, today, 13.1 is not really a very good success rate, and even 22.8 is not a very good success rate. So, but these were the results at that time, because Henne and Milke produced this paper in 2004. What they did is that they did the dummy embryo transfer, and then they looked again at the patient during the actual embryo transfer. And what they discovered is that the uterus changes position. It was antiverted in 623 cases, but when they went to the actual embryo transfer, only 608 remained in the antiverted position, and there were 213 in the retroverted position. But when they came to the actual embryo transfer, 118 of them became antiverted. So the uterus changes position. So it seems that doing the trial embryo transfer long time before the actual transfer may not be that helpful as people may think. Full bladder. Is it helpful to have a full bladder? And the short answer is yes. This is meta-analysis by Ahmed Abu Satta from Canada. As you can see here, the clinical pregnancy rate is improved, the live fertility is improved, and this is probably because the full bladder diminishes the uterocervical angle, which is usually the place where we have the problem. What about removing the cervical mucus before doing the actual embryo transfer? Now, these are two studies, again, Raga Mansour and Nabi, and actually they did not do a randomized study, and they don't work on actual IVF cycles. Mansour looked at the expansion of the dye. She put a blue dye, and she looked whether after removing the cervical mucus or without removing the cervical mucus, whether there will be expansion of the dye, and she found yes. And Nabi found, when he worked with real embryos, he found that there was embryo retention if you do not remove the cervical mucus. What about flushing the cervical canal? Some people like to flush the cervical canal with calcium medium or a similar solution with proper pH and osmolarity. Well, Paul McNamee from Honolulu in Hawaii conducted a case control trial a long time ago, and he said at that time that he could improve the clinical pregnancy rate when he did flushing of the cervical canal prior to embryo transfer. But when we did our randomized control trial, we actually didn't find any difference thereof. What about avoiding the teneculum? Well, nobody has done a randomized control trial to do this. You cannot. It would not be ethical to hold the cervix with a Volcellum just because you're doing a randomized study. But what Renato Fanchin has done is that he came up with a method to measure uterine contraction, and it was Lesney who did this study and studied these contractions when you hold the cervix with the teneculum. And what he found is that there are some cervical fundal contractions from below upwards, and there are fundo-cervical contractions from above downwards. And there were some random contractions and opposing contractions. And let us stop here. So there were contractions. Yes, if you hold the teneculum, you have more contractions. But let's ask ourselves a question. Who said that the contractions will come from below upwards, like the cervical fundal contractions are detrimental? Maybe they could help the embryo. And indeed, when Tremelin conducted this randomized control trial, he found by allowing some people to have intercourse around the time of embryo transfer versus those who are not allowed to have intercourse around the same time, they found that pregnancy rate was actually the same, no change, but the implantation rate, if anything, was better if people had intercourse. So these contractions are not necessarily detrimental. What about ultrasound-guided embryo transfer? Is it better to do an embryo transfer under ultrasound guidance? And the short answer is definitely yes. Well, the first people who did ultrasound-guided embryo transfer were strictly Italian. They used ultrasound to look at during embryo transfer, and what they said that there were advantages, like that the transfers can be done in the lithotomy position, that the catheter tube can be accurately positioned, the fundus, ejection of the transfer bubble can be documented, and observation of the bubble is comforting to the patient. That actually we took things a little bit further. We thought that the important thing really is the uterocervical angle, because this is the point where most of people will have difficulty. The catheter will go inside the uterine cervix and then will stop at the internal os, and then this will be where the point where difficulties can happen. So we measured the uterocervical angle, and we found that yes, some people do not have an angle in the first place. Some have a mild angle, a moderate angle, a severe angle, and some people have a retroverted uterus. So actually, when the first um, paper came on ultrasound guided embryo transfer, people started to do this and published many studies. Some of them were case control trials, some of them were randomized control trials. And you see, these 5 papers, for example, said yes, ultrasound helps you. It increases the clinical pregnancy rate. But then some other studies said no, it did not make any difference. So what was the answer? The answer was, of course, to do a meta-analysis, which we did many years ago and published it in 2003, Infertility and Sterility. And what we found is that, yes, the clinical pregnancy rate is definitely increased, and the implantation rate is definitely increased, and also the ongoing pregnancy rate is also increased when we do ultrasound-guided embryo transfer. In the same issue of fertility and sterility, uh, William Bucket from McGill University in Montreal showed the same thing, actually the same figures, because he did the same meta-analysis. So yes, ultrasound-guided embryo transfer helps increases the clinical pregnancy rate. But then came, and this was the Cochrane review at that time, which was published in 2007, including all these studies, even more studies than we had in our meta-analysis, and they showed that the clinical pregnancy rate is improved, the live birth rate is improved when you do ultrasound-guided embryo transfer. Then came this paper in 2008, and this paper claimed that it was a randomized controlled trial of 2,000 odd patients with ultrasound, and they said, well, we did not find any difference. And we think that the Cochrane review should be updated, which was done. And when the Cochrane review was done and the meta-analysis was done, and then the ongoing pregnancy rate showed improvement, but the live birth rate did not show improvement. But then we looked carefully at this paper, and we discovered that it is not really a randomized controlled trial, because people who did this from Liverpool used actually different catheters in both arms of the study. In one arm, they used a soft catheter, and in the other arm, they used a firm catheter. And then they say at the bottom of this slide, as you can see, that they wanted to pragmatically test 2 methods holistically: ultrasound plus echogenic soft catheter versus clinical touch with a non-echogenic soft catheter. So they used different catheters, which really violates all norms of randomized controlled trial, because when you remove this study, we actually find that yes, with more studies also which were published in the literature. Now the new Cochrane review, which was published in 2016, as you can see here, confirms that yes, when you do ultrasound guided embryo transfer, you have a better clinical pregnancy rate as well as a better live birth rate. Some people also used, all what we were saying before was about abdominal ultrasound guidance, but some people also use transvaginal ultrasound guidance, which is a bit cumbersome, of course, but some people use a very slim transducer, vaginal transducer, and they claim that they can do this. And some people even, and as you can see here, this is the vaginal ultrasound study, and some people even used 3D ultrasound. The group of Professor Alan Cherney when he was still in University of California, Los Angeles, UCLA, and as you can see here, published in 2005. Okay, so the next factor is the soft versus the rigid catheter. Is it better to use a soft catheter? Well, William Bucket did this study and meta-analysis, and he found that yes, when you use a soft catheter, you get a better result, a better clinical pregnancy. And another study by Abu Sata, another meta-analysis showed the same result. Yes, when you use a soft catheter, you have better results. However, they were not talking about ultrasound-guided embryo transfer, because when Ismail Abul Futuh from Cairo purified the study, did subgroup analysis and used only soft catheters versus firm catheters only in people who had ultrasound guidance. Now there was no difference because when you do ultrasound as we do, we measure the angle and then we bend our catheter according to the angle, in which case there will be no difference between the soft and the firm catheters in terms of clinical pregnancy rate, implantation rate, and ongoing pregnancy rate. What about having air in the transfer catheter as I described before? As you can see here, there are three drops of medium. The middle drop contains the embryos, and there is a proximal one and there is a distal one. And between these three drops of medium, there are two air bubbles. Is this good or bad? Does it make a difference? And the short answer is no. Airing catheter versus no airing catheter. No difference according to this randomized controlled trial. What about the site of embryo deposition? Is it maybe? Let's have a look. Well, Corollo conducted this randomized controlled trial, Corollo, Italia. They conducted this study, and they showed that the further you stay away from the fundus, the better. You see, in group 1, they put the embryos at 10 millimeters away from the fundus, and the success rate was 20. But when they went a little bit away from the fundus at 15 millimeters, 131, and at 20 millimeters, 133. So yes, we should not be too near to the fundus. The same was done by Pope Italia, and what they have also found is that the more you stay, with each millimeter you stay away from the fundus, you increase your success rate, your clinical pregnancy rate by 11%, at least according to their study. What about waiting 30 seconds before withdrawing the catheter? No difference. As you can see from this randomized controlled trial, there are not many patients, 50 odd patients, but at least in this study, there was no difference between waiting 30 seconds or not waiting 30 seconds. What about the time between loading and discharging the embryos? Sometimes you go with the outer catheter and the embryologist is coming with the inner catheter with the embryos inside them. And then you do not succeed into getting into the uterine cavity with your outer catheter, and the embryologist is waiting. How long can he or she wait? Well, the answer is 2 minutes. As you can see here, the results, the implantation rate and the pregnancy rate did not change until 120 seconds. After 120 seconds, the clinical pregnancy rate dropped from 31.6 to 19.1, and the implantation rate again from 15.9 to 9.4. So 2 minutes should be the maximum for staying outside the incubator. What about having an adhesive compound to help the embryo stick to the wall of the uterus? Well, contradiction. Barhava, Italia, in 1999 conducted the case control trial and said it works. When Feichtinger had done a randomized control trial, and he said it doesn't work. Again, Valogiardi tried the embryo glue, and he found no difference really. And now the verdict. And now we have a new Cochran review, our review, which was published in 2014, and they had that. And they said that the quality of evidence was moderate, and they said that it does help a little bit. As you can see, the live birth rate, clinical pregnancy rate, and the multiple pregnancy rate also was increased. However, in a different meta-analysis, we could not confirm these results. When we actually scrutinized the studies, we could not include them all, and when we included the really serious study, there was no difference really made by adding the adhesive compounds to the embryo transfer fluid. Another suggestion was to inject human gonadotrophin 500 international units prior to embryo transfer. Actually, it was Rega Mansour from Cairo who suggested this, and she conducted this randomized control trial and said that it does increase the clinical pregnancy rate, and this work was repeated by Santi Bagnese, Italia, who found the same result. and then the implantation rate was also increased. When the meta-analysis was done of all the studies on the subject, it was found that if you add less than 500 international units, you don't get it. You have to add more than 500 international units equals or more than 500. It only works in the cleavage stage embryo transfer. If you are adding blastocysts now, it doesn't really make much difference in terms of clinical pregnancy rate and also live birth rate. Another suggestion was the mechanical compression of the cervix after embryo transfer. After withdrawing the catheter, after embryo transfer and withdrawing the catheter, one can hold the bevels of the speculum tight, compressing the cervix like this. And this was another suggestion by Raga Mansour, and it was a single study, and we are waiting for other studies to confirm this initial observation. Bed rest after embryo transfer has also been suggested. However, studies have shown that it does not really add much, and these are two randomized controlled trials and one cohort study. And when the meta-analysis was done, our Cochran review was done, we found no difference in the clinical pregnancy or the ongoing pregnancy thereof. What about using routine antibiotics after embryo transfer? Now, the first question is, does infection affect embryo transfer? And the short answer is yes. These are 4 studies from the literature showing that yes, if you have infection, then your clinical pregnancy rate is going to be diminished. And the meta-analysis which we have conducted many years ago showed the same thing. Of course, the clinical pregnancy rate is diminished and the implantation rate is also diminished. So what is the answer? What Patrick Agbasi has done is that they added antibiotics only to those patients who had an infection, either at the tip of the catheter or in the cervical mucus. They cultured the tip of the catheter after embryo transfer, and when they found an infection, they added antibiotics. And by doing this, they improved the implantation rate and the pregnancy rate. However, by giving antibiotics to everybody across the board after embryo transfer doesn't seem to work, as we can see from this randomized study by Pekrishvili, Italia, published many years ago. What about the experience of the clinician? Does it really matter? And the short answer is yes. If you have, sometimes in many centers, the embryologist records the results of the different clinicians. As you can see here in this study, clinician A was doing much worse than clinician B. Clinician B had always a good pregnancy rate, while clinician A did not have it. And in fact, if you train the midwives, they can be as good as gynecologists, if not better. These are 2 studies, one from Oxford and one from Scandinavia. And you can see here the results were as good in both the nurses and the clinicians. And what Papa Giorgio found is that you really need 50 embryo transfers to acquire proficiency. So these are the factors that affect embryo transfer. Finally, we come to the management of difficult or intractable transfer, because sometimes you do many things and then you're stuck with an intractable embryo transfer and you cannot put the embryos inside the uterine cavity. So what do? Well, the first thing to do in these cases, of course, is to change the catheter. There are catheters with a stylet, and then this allows you to bend the catheter according to the angle of the uterocervical angle, as we said, which is usually the place where the difficulty is present. So we bend the catheter according to this using a catheter with stylet. But if it doesn't work, there are other options which we are going to show here. So here, this is the catheter with the stylet, as I said, which is specific for difficult transfer because it has the stylet which one can bend according to the inclination of the uterus or the angle at the uterus cervical. Then people have tried to do transabdominal transmyometrial embryo transfer, to do it through the tummy and do a transmyometrial embryo transfer. To cut a long story short, it is not successful. They have also tried to do it transvaginally, as you can see here. The needle is going through the vagina, guided by ultrasound, as we would do with oocyte collection, and then the catheter is put inside the needle, a wide-bore needle in this case, but again, the result was not very impressive. Another possibility, of course, is to do zygote intrafallopian transfer, is to do our embryo transfer through the fallopian tube. But of course, this is only if the fallopian tubes are clear, like cases of ICSI, for example. But of course, this is a more complicated answer to the problem. Because the best answer really in these cases is to freeze all the embryos and then do the embryo transfer at a subsequent cycle, after which one would have sorted the difficulty in the cervix, even by doing dilatation of the cervix or using maybe a hysteroscope to do this dilatation, and then do the transfer of the frozen embryo at a subsequent cycle. And this is the meta-analysis showing that if you freeze all your embryos and put them back, there is no difference really, even if you put them at the cleavage stage or the blastocyst stage, you still have the same live thread. And although in fact the Cochran review shows that you even may have a lower incidence of miscarriage, and maybe nobody knows why exactly, but this was the data as you can see them in this Cochran review actually. The frozen embryo transfer, the clinical pregnancy rate. So in conclusions, ladies and gentlemen, the following procedures have been shown by randomized control trials to improve pregnancy rates. 4 things. Doing the embryo transfer under ultrasound guidance, putting your embryos in the mid-fundus deposition away from the fundus. The soft catheter is better than the rigid catheter only if you're not using ultrasound, and then performing the embryo transfer with a full bladder. These are the 4 things that have been shown to improve pregnancy rate. And meta-analyses have also shown that 2 things significantly diminish the pregnancy and implantation rates: difficult embryo transfers and cervical infection. But there are a group of factors which do not affect pregnancy, and randomized studies have shown that these things do not affect pregnancy, like staying in bed for a long time, waiting 30 seconds after embryo transfer didn't make much difference, having sexual intercourse around the time of embryo transfer, the presence of air in the embryo transfer catheter, or the routine use of antibiotics. All these things do not seem to change the pregnancy rate. And finally, there are things which need still to be evaluated, like the position of the patient during embryo transfer, general anesthesia, dummy embryo transfer, the removal of cervical mucus, flushing of the cervical canal, avoiding the use of a teneculum or a valcellum, and the use of a fibrin sealant. All these things have been suggested, as we said, but the results are still not conclusive, as we saw. And finally, in difficult or intractable transfers, there are options. Changing the catheter is the first option. Then transabdominal, transvaginal, and zygote intrafallopian transfers are not really very good answers, because the best answer in this case is to freeze all and put the embryos back in a subsequent cycle after dilating the cervix by simple dilatation or hysteroscopy. And with this, I come to the end of my presentation, and I would like to thank you very much for your attention.